Good afternoon. I want to thank the organizers for the invitation and certainly the Aging Brain Initiative for putting faith into our work and funding this project. My name is Thomas Heldt, and I present work here that I want to specifically acknowledge Jane Lai, Gladnell Saavedra-Peña, and Jamie Kerner, who are the students who have contributed to this project, and the faculty colleagues are Charlie Sodini, Vivian Z, and myself. I'm located at the Research Lab of Electronics and the Institute for Medical Engineering and Science, and most of my work in the past has really, still in the present, is related to traumatic brain injury and technologies that we can translate to our clinical colleagues into neurosurgery and neurocritical care to help our clinician colleagues take better care of patients with significant injuries to their brains. One question that often arises when I talk to my neurocritical care colleagues, neurologists, is can we have a better way to assess the neurocognitive state of a patient? When you do that as a clinician, you come to the bedside, you speak to the patient. If the patient is alert and oriented, you can do various tests about the visual field. A lot of this depends, of course, on the acumen of the physician and the clinical expertise and how often the physician has seen the subject or the patient. When we talk to our colleagues around campus here, the pharma industry, they're looking for biomarkers that can be integrated into clinical trials so that they can have something quantitative to measure in between bringing a patient in who is a subject in their clinical studies. So we started to look at this, and tracking the normal aging process from a neurocognitive state or the disease progression if a disease has been diagnosed is actually not that easy. Where I sit in the Department of Electrical Engineering and Computer Science, what has been fundamentally revolutionizing our world, not just our world, but everybody's world, I guess, is microelectronics. And we all carry these evil devices with us, and we're collecting data continuously on us. In this other space in which I operate, we are taking devices in the medical environment that are the size of fridges, and we're miniaturizing them to the point of a size of this kind of technology. And the question here is, can we do the same thing? Can we help our clinician colleagues in providing them with clinical features that the patients can actually take home? You don't have to bring them in, and you can do longitudinal tracking. So the goal here is to design and to implement embedded tools that enable individualized and longitudinal monitoring of these kinds of digital biomarkers to assist in the diagnosis and assess disease progression. The field that we're in here is normal aging process, but also disease progression of neurocognitive state. The kind of things that we're thinking about in the latter part is Alzheimer's disease, Parkinson's disease, but also other kind of conditions. And why consumer electronic devices, as I already mentioned, because we tend to carry them around and everybody tends to have them. These kind of devices are non-obtrusive. They are low cost, have a high penetration in the market, and typically does not require a trained operator to come into your home and to help you take data. Also more frequent data in the wild. What I mean by that is we all know when we go to the hospital, there's a white coat syndrome, your blood pressure tends to go up. It's typically not representative. You do a spot measurement that might be happening every half year or so, and there's quite a bit of literature out there that says that measurements done unobtrusively and at home are quite different from the measurements that we do in the clinical environment. So there's a bunch of digital biomarkers that we could think of. We could think of voice, we could think of behavior. All of these things can be measured with these. The ones that we've started to think about is eye movement. Turns out that the cameras that we have, or you probably all know that, the cameras that we have on these are actually quite extraordinary from the resolution. And there's a big body of literature that says that or there's a lot of evidence that aging and neurocognitive disease progression can manifest often in changes in eye movement patterns. And here what I'm showing on the left-hand side is normal elderly subjects compared to mild cognitive impairment, compared to patients who have been diagnosed with Alzheimer's disease. And the point that I want to make with this slide over here is also that each of these dots represents one patient, meaning that you come in, you take a measurement, you get a dot, and then you come back half a year later or a year later, depending on the assessment of the clinician. And there's spread in the variabilities, there's a change in the mean visual reaction time that I'm using here as an example. And there's a whole host of other conditions where you can do the same thing. You can look at different eye movement features, not just visual reaction time, but that's the one that I'm focusing on in this presentation for now. If you look at the far right, this is progressive supranuclear palsy, PSP. The difference between the vertical and the horizontal movement really becomes diagnostic. And it's usually something that people or physicians only look at the very end if they cannot identify or pinpoint the disease progression through other means. So the visual reaction time in this particular case is larger and tends to be more variable as the disease progresses. So I've already alluded to the measurement approach. You're being brought into an environment that is usually well controlled, meaning that lighting is controlled. There is usually an IR source, infrared light source, that is shown on your eyes, and through simple ray optics, you're trying to figure out, or you can determine where the subject is looking. Again, you wouldn't bring someone into a clinical environment like this on a daily basis to see what are the fluctuations in these kinds of metrics. On the left-hand side, an older version. Now, of course, you can have that all miniaturized and built into your glasses, but you still have to carry the power pack around. On the right-hand side, what you also see is usually the head is in a headrest, so to minimize head movements and to not confuse head movements from eye movements. And in a clinical environment, typically the environment is, the ambient light is controlled so that you have a very well-defined environment to do these measurements. So you need capital equipment, you need people, you need to bring people in, you have to have technicians or physicians who conduct these kinds of experiments. And all of that means that you only get highly intermittent data. All right, so we want to go from something like this to something that we can record on devices like that. But we want to do this to clinical grade. As I said, I will focus here on visual reaction time. I'll point you to a poster that Jamie is actually presenting in the poster session. So if you have questions about some of the more recent developments, he will be out there and he'll be happy to show you the device. I've got verbal assent from the subject to be shown. And so here are two tasks. You can play along if you want. This is a task where the subject focuses on the center point, and then that center point will disappear, and in a randomized fashion, the visual target will either occur on the right or on the left. And the subject is asked to move as quickly and as accurately towards the target. So I hope this works. And as I said, you can play along if you want. The stimulus is at the top. And the task, I think we have either 20 or 40 of these individual eye movements that we record in this particular task. It takes less than a minute. Right? And the subject is also kind enough to just blink when or tries to blink when the gaze is at the center. Now this here, I'll spare you the rest. It's called a Prosecar task, where you are actually jumping towards the target. Now we'll do something slightly different, and we go to this task over here. Now, it's the same stimulus. It's just when the stimulus appears, you're supposed to jump into the opposite direction, right? So disengage from the impulse that they have to jump towards, disengage, and jump to the opposite side. And if you observe the subject, good, okay, good, and there you see, right? So if you were not utterly convinced that this is a very worthy task and that you are advancing science, you could really think that this is an annoying task, right? Because at some point, I completely switched, right? I started off jumping in the opposite direction, and then your mind starts wandering somewhere, right? And you actually start, and that is information in and of itself. So what we have over here, what we can measure is the reaction time. It is the error rate. And if you go to Jamie's poster during, in the afternoon, you can also see that we can measure the amplitude, the velocity, all these kinds of things. So this is called an anti-saccade task. And as I said, in the remainder, I'll just focus on these two tasks. So we built a pipeline where we use an eye tracking algorithm that we adopted from colleagues here at MIT. We get the eye movement trace in the horizontal direction. We time lock that measurement with when the stimulus occurs, and then we can get the reaction time. And because we can do this rather quickly as a function of just in a matter of a few minutes, we can get a whole histogram of the distribution. We're not robots, right? So we have a whole histogram. Now, the technical innovation here, where you really have to be careful, is because you are displaying something on the screen, right? And you're grabbing frames from the camera. So that synchronization, you have to be a little careful, because these things can tend to actually drift apart, and you have to compensate for that. So first, looking at the eye tracking algorithm, this is work that we adopted from Antonio Torralba's group here at MIT in CSAIL, where we use a convolutional neural network. We take the whole face, we overlay a face grid, and we predict the eye gaze both in the X and in the Y direction. For our purposes, all that we're looking at is really the X coordinate, because we have the targets to the right and to the left. From this, we can then look at the onset detection. We know when the stimulus occurs because we're in control of that, and then we can model that behavior. And what we've overlaid on the data over here is a simple hyperbolic tangent fit, where we can then use this fit in the transition region, but also in the slide region before and after, to assess the goodness of the fit, meaning that we can quantify the goodness of the fit, and we can use that goodness of a fit to actually throw out some of the data and to reject and accept. We don't want to base our analysis on data that we haven't vetted. So we, and by we I say the graduate students, annotated about 10,000 of these traces into good and bad and ugly. And from that, by using a normalized root mean squared error threshold, we can classify these into good and bad traces. And the average true positive rate is here 0.87, average false positive rate is less than 0.2. The important thing is that we can always collect more data. It only takes a few more seconds to get maybe 2 or 3 more data points. It's just that we want to reject those that are overtly artifactual, right? So, and then after this 10-inch fitting, we can compare the recordings, of course, against the ground truth. We want to make sure that this is not just gadgetry, but we want to make sure that we really capture with the same accuracy and precision what you would actually measure in a clinical environment. So on the left-hand side at the beginning, we looked at iPhones. Now we're looking more at tablets because it gives us a little bit more range of the in amplitude. So we used consumer-grade electronics over here. We also spoke with a colleague who does a lot of high-speed videography. So we borrowed her $100,000 camera that we were able to synchronize with the stimulus. And here's just the comparison of 2 subjects. So on the left column is what we measured with the iPhone. On the right column is what we measure with this $100,000 camera. And you can see that not just the first order moments and the second order moments, right, but the whole distributional characteristics is pretty much the same, right? And so I think we are at least convinced that for a high enough amplitude measurements, we can use these kinds of technologies to the same accuracy and precision as some of the clinical grade technologies. Okay. So this is the now fully automated pipeline that runs in the background. And so where do we stand? As a reminder here, this is what we want to get away with or get away from. Of course, you first do it on yourself. And here are the distributions for just 4 subjects, for both in blue pro-saccade latency and red is the anti-saccade latency. And I want to draw your attention to these kinds of numbers over here, right? So subject 1 provided about 5,000 or so individual eye movements. And that was over the course maybe of about a month. So what we did is we asked subjects to take our iPad, please bring it back, and do one set of recordings maybe around lunchtime or in the morning, and another set of recordings in the evening. And you can easily accumulate a lot of data over that period of time, and you can have these very tight distributional characteristics. And as I said, subjects 1 here, subject 2, 13,000 saccades over maybe about a couple of months or so. So these are numbers that you would never be able to get if you bring subjects back into the clinic. Likewise, we can look at the error rates and the error rates for the pro-saccade task, as you probably already saw in the videos that I showed, tend to be fairly low unless your mind really starts to wander, because it's a very natural thing to do to move towards the target. Tends to be much higher when you actually have to actively disengage, wait until the target is in your peripheral vision, and then jump to the opposite side with the same magnitude. Okay. The other thing that you can start to look at is test-taking strategies, right? Because there's a couple of things that you can, of course, you can be very fast, but you're probably making errors. Again, the directionality was randomized, right? So if you have 3 going in one direction, you might guess, well, the next one is it must be coming in the opposite direction, right? But not always. If you ever flipped a coin for long enough, right, you see that long sequences of heads or tails actually do occur. So if you look at subject 1, for example, the anti-saccade certainly is shifted in terms of the mean latency, but this subject is willing to have a higher error and for both this pro and anti-saccades. Subject 2, for example, is actually quite impressive. Keeps the error rate constant, right? Shifts the latency a little bit. And then you see subjects 3 and subjects 4 have a little bit of a trade-off, right? You have a little bit of a line going across. So we've rolled this out across the age spectrum, where what we did is, of course, you ask your friends, your family, the students ask their friends, and we were able to now look at the various decades of life across the spectrum. And over the course of about, I would say, maybe about 9 months, we were able to recruit 100 subjects. We have over 250,000 eye movements. And if you look at the first and second order statistics here, you can see that as you progress through these different decades of life, the mean latency goes up, but also the spread actually goes up quite substantially, right? Now, this is pooled data. You could say, well, this is because you're actually pooling data from different subjects, and that gives rise to a broader and broader statistics. What we can also do is, of course, we can look at the individual statistics. We can track the individual subject. On the left-hand side, we have a subject that's in their 30s, or his 30. I gave you the gender as well as here. And on the right-hand side, we have a male subject in their 60s. As a function of time, and here we say trial number because sometimes subjects forget to do it on a particular day. So this usually is consecutive days, but might be interrupted. So on the left-hand side, we have about 12 days or so of data, and you see that there's not much variability amongst the blue, and amongst the red. Whereas on the right-hand side, you see more significant variability. Now, in the app, of course, we ask subjects about how tired they are, whether they've taken their medications, if they are on particular medications that they're willing to share, so we can incorporate all of that into our analysis. We can also look at the cumulative error rate that is now cumulative over time. I think we had the longest that we had someone to contribute data at about 3 months or so, and at some point we said we would like to have the iPad back, but they really got into the habit of doing that. All right. So what about normal aging? So I hope that one of the things that I've convinced you of over here, or even on the single subject data, is that there's quite a bit of variability. And putting that and distilling all of these distributional characteristics into a single number might, you're throwing a lot of data away that we would like to keep. And there might be important information in that in and of itself. So there have been some publications about similar work where you have to come into the special clinical environment, mean saccade latency on the left-hand side as a function of time for different types of gap paradigms of the pro-saccade. On the right-hand side, you see the also pro-saccade data for individual subjects across sort of the larger age spectrum, or the older subjects. Same for anti-saccade. Quite a bit of variability, both in terms of how these features evolve with age, but also at an individual age category. And we've been able to reproduce that in our own data. So in the dashed lines over here, what I show you is some of what has been reported in the literature. Our subjects tend to be a little bit faster. I don't know whether that's sort of the phenotype that we have at MIT. We're impatient, right? But we make, at times, more errors, right? And as we now think about how do we apply this to normal aging, the normal aging process, or superimpose neurodegenerative disease progression, for example, one has to take into account that there is a trend towards higher latencies and potentially even to higher error rates as you progress in age. So going beyond just the saccadic eye movements, or the latency and the error rates, please see Jamie's poster. He's also looked at smooth pursuits. He's looked at fixations, self-generated saccades, and so I don't want to steal his thunder. But I want to just mention some work that we've also done. Of course, we know a lot about the visual oculomotor system, right? And we can formulate, at least at a higher order level, mathematical models that represent the controller system and the plant, the oculomotor system. We've done that, and what we are showing over here, that if you're not interested in one particular eye movement, but you might be interested in superposition of these eye movement, we're thinking of saccades over here, smooth pursuit eye movement, and fixation eye movements, all of these superposed to then move the eye in particular ways. So we've built these kinds of models. The oculomotor plant is then, the response of the oculomotor plant is a superposition of these signals, and the output at this level is a noise-free realization of that superposition. We can formulate these, at least at the beginning, in terms of a linear state space model that might evolve over time. The interesting part over here is that we do the measurements, which are a compound of these individual controller mechanisms. And what we asked ourselves in this particular work, can we actually use more natural eye movements than the ones that is this stimulus response characteristic to deconvolve or to invert these kinds of mechanistic models, and then determine what is actually happening to these controller mechanisms. And we've applied this here to some of the data that we have already in our database. This is from an older subject, I think in the 70s, and you see that this particular subject needed 2 saccadic eye movements to get to the target. And by applying or inverting the model that we have over here, we can come back and we can at least have a purported controller mechanism that would allow us to then figure out whether there's a superposition of saccadic eye movements, smooth pursuit, and fixations, and to look at these then individually in a more phenotypic way. Okay, with that, let me just jump over these conclusions over here, but just say that what we've demonstrated, and we were able to demonstrate here also with support from the Aging Brain Initiative, is that we can get massive amounts of data by deploying these kind of technologies at clinical grade. and at the patient's or the subject's home. We believe that that opens up a whole new opportunity for studying not just aging, but neurodegenerative disease progression, but also other pathologies. For example, concussive injuries, we know in children is also related or has effects on oculomotor function, and we're working with clinician colleagues here in the Boston area to deploy this in patient populations, but also internationally in children with concussive injuries. As I said, Jamie has a poster outside. I encourage you to take a look and to see where he has taken this over the past half year or so. Thank you. So when you say diagnostic, you mean actual diagnosis, right? Yeah, so I think the way that, so what is the next step for us, right? The diagnostic part is difficult because you never really rely on a single piece of information, right? It can be an adjunct to all the other tests that our clinician colleagues would actually do, and that's one thing. Right now, I think the next step for us is first to actually give it into the hands of a number of patients and of a fairly well-defined characteristic. And what we are thinking of right now is, on the one hand, is Parkinson's disease, and on another hand is the concussive injuries for very different reasons. But then sort of baby steps. The first thing that I would like to do is I would like to see whether we can reproduce the kinds of data that have been reported in the literature in gold standard measurements, sort of the clinical measurements. But then I would like to also see, for example, in Parkinson's patients before and after DBS, for example, or before and after changes in drug regimes, whether we can actually see the changes. Of course, the efficacy is established, with our neurosurgical, neurological colleagues, but it would be interesting to see whether we can see these kinds of differences also in the oculomotor function. At that point, I would like to then leave the iPads with these patients and say, if you're willing, can you give us like 3 months worth of data? Here, I showed some of the data. We have quite significant variability in the data. Some of that is simply normal. Right? Some of us, you're more tired, you're less tired. And any change that is due to the neurodegenerative disease process must be viewed in the context of the ordinary variability that we already see. Right? Alzheimer's disease is a little tricky because some of the mechanisms are very slow. Right? And so I don't want to keep the graduate student here for however many years it takes to get a good delta. Right, so we're looking at also to international colleagues at some of the more rapidly acting neurodegenerative diseases.
I wonder, is some of the variability that you see due to problems with divergence and convergence, which is really hit early with aging?
Yeah, could be.
Measure that. Just gave that one measurement.
Yeah, I haven't thought about that.
Really, really good.
Okay, yeah.
Beautiful work.
Okay, thank you. There was a question. Oh, sorry, first.
Yeah, I guess I'm curious about, the videos you're taking have entire people's faces, I guess. And I wonder whether there's other, such rich data as far as
sure,
face, muscle movements, expression.
Absolutely. So let me give you one example, right? So I've done this every every hour of the day. Right, when you're tired, your eyelid droops, right? Your blinks become very slow. So one of the things that we've looked at is fatigue. It's just tiredness. And we just had a paper presented early in the summer on that. If you're really interested, you could also look at sort of ballistocardiographic movements of the head that could actually give you cardiac pulsations, respiratory variation. Yeah, all of that. There's a whole host of information that you could try to get at, and some of that we've already harnessed.
Thank you. There was such a wealth of data, so maybe I missed it. When you saw the sort of faster speeds, right, in the MIT population versus not, is it possible that that's
Yeah, so we looked at that at the beginning.
Yeah.
So because we have repeat measurements, we saw whether they are sort of like and some subjects really you see a learning effect at the beginning, right? But then you really stay fairly steady. So we tend to throw out the early ones. Others, no, the early data because it's a learning effect, right? And we don't throw out the.
Right? You study learning.
Sorry?
You can study learning for free.
Yeah, that's true. So no, so for this kind of analysis, we didn't throw out the data. No. We never throw out the data. No. But others, contributed for, I don't know, 2-3 months, and we didn't really see a systematic change, right? We do see variability on the day-to-day, and we also stratified by time of the day. We stratified by tiredness level, and you can reduce some of that variability through that substratification, but there's residual variability that you can't get rid of. Yeah, please.
So recently I visited a friend that just had a child, and he's grown up using devices like this all the time. And one day I saw that he handed him a book, and the child was trying to swipe up and down
Sure.
the book. So it's like
Yeah.
the behavior of the child changed because of how he's grown up. And so how do you think this would affect the type of data that you're acquiring?
I think. Oh, so sorry. Yeah. So the question is, the younger generations are growing up with these kinds of devices, right, and are very facile with using, but might not be as used to reading books anymore. And how does that affect our work? I think we will see. I mean, we will have to see. The younger subjects are faster, but some of that is also borne out by literature that is older, right? So I don't think that we systematically have seen yet that kind of trend in the data, right? Most of what we're interested in sort of the aging brain, of course, happens at the higher age spectrum right now, and sort of it will take a little bit of time to, for the very young to come, through that profile. In the concussive injuries, you are talking about a much younger patient cohort, and there it might manifest itself. We would have to see whether people are very have a lot of experience with gaming, for example, where a lot of that eye tracking is also of importance, where you might be more attuned to more rapid movements. But this is just one of many features that we can look at, as we mentioned before.
Last question.
Yes, great talk, thank you. You had one chart that showed the scatter of the data for Alzheimer's versus normal, or not normal, but
mild cognitive impairment.
Yeah, kind of a scatter.
Yeah.
So
Where is it?
clearly the average was going up, yeah.
Slightly, yeah.
But there's still quite a bit of overlap for your normal elderly group. So within the Alzheimer's, I don't know what data tracking. Are some that are in the normal, are those earlier Alzheimer's?
Exactly right. So one of the things that we're negotiating with our clinician colleagues is that we want to do we want to know sort of what spectrum of the disease process people are on. So we need access to the clinical data. It's not just yes or no, right? So of course, if you throw everybody who has a diagnosis of X into the same bucket, especially for disease conditions that we know are progressive, right, you will end up with a huge variability. Right? That's why it's important for the next step to actually you have very good phenotyping of the disease state compared to standard clinical tools. Thank you.